Hi you epic humans, and welcome to episode 4. We've switched over to episodes now because this is my own show, the one about birth. So first of all, I'm going to apologise if I don't talk toppily tonight. I'm pretty knackered. For those who don't know, I was admitted to hospital last night. I'm totally fine. I've just got a crappy infection on my leg and I needed some IV antibiotics. So I'm fine, but I'm pretty knackered, so hopefully we will get through this. Don't go to bed on me because I want to go to bed too. Alright, so I just wanted to touch on induction. It wasn't something I really wanted to talk about tonight, but I know a lot of you are nearing the end of your pregnancy or you have an induction booked. If that's the case, your care provider should have gone through the process with you. Next week I'm going to go through the process for those that aren't up to that stage yet, so they're a bit more aware of it. But I just wanted to touch on choices and reasons for induction first of all. So if you have one booked and it's absolutely necessary, so there is a medical reason for it, or you have chosen it because it's the right choice for you and your family, then everything that I have said over the last 3 weeks applies to your induction as it would if you had gone into labour spontaneously on your own. So that includes all the labour and birth techniques I've gone through, and the mindset. So your mindset, believing in yourself, believing in your body's ability. Just because you're having a little bit of medical assistance, and you may end up having, some of you may have a little, some may have a lot. Just because you're having that doesn't mean that your mind and body aren't working really hard. Now, if you go into your induction going, this is going to hurt more because my hormones aren't going to be working as much, I'm not going to have endorphins, and everyone's told me that it hurts more, and I'm not going to be able to do it, or my body hasn't done it, so I'm not going to be able to, labour properly, then, like I said, exactly the same with spontaneous labour, that is going to negatively impact your labour and birth. If you go into it going, I can do this, my body can work with this induction, I am strong, I was made to do this, this can be the most empowering event of my life. And I really want to touch on that. I have been at some incredible inductions over the last 13 years. Absolutely beautiful, empowering labours and births. And sometimes the birth isn't empowering, but the labour is. And that goes for spontaneous labours as well. Sometimes the birth ends up in a way that you didn't want it to, but you can look back and go, I'm really proud of myself because I did all of that and I made the choices that were right for me, and I was, I hit a couple of crossroads and I didn't really want to hit those, but I was informed and I made the right choice, and I was happy with how that journey unfolded. And if you tuned in last week on Instagram with the birth mapping, you'll understand where I'm coming from a bit more. And if you've got my pregnancy program, Catherine Bell's actually done a huge presentation for us on birth maps to explain it all as well, so that's been added this week. So if you need induction, if it's medically indicated, go into it as you would a labour that wasn't being induced. Go into it as mentally and physically as prepared, believing in yourself, knowing your body's capability, and working with your body and the induction. Keep the lights turned off, use your TENS machine, get in the water, shower, bath, have massage. All those things apply, okay? So please don't be scared of induction. It can be an absolutely incredible, beautiful birth. And if that's what you need, then that's your way forward. Embrace it and go with it. The other side I want to touch on is the inductions that aren't necessary. And too often we see these. Induction rates are just increasing and increasing and increasing. And it's almost like it's this... it's a normal question to ask people and be asked when you're pregnant. When you're getting induced, have they booked your induction yet? And that absolutely kills me, because it just makes birth about this factory where we just stick you on the conveyor belt and get you out again. Birth wasn't meant to happen like that. Labour wasn't designed to be like that. My husband has a question.
We need to turn the volume up. We need to turn the volume up.
Turn the volume up?
Yeah.
I don't know how to do that. Can people not hear me?
Mm.
That one? Under there?
Yeah, possibly, but that's your volume.
Yeah.
Oh,
Wouldn't that
try.
be it? Can you
TV's
hear
up
me
to
a bit?
63. People back fanning
hard?
can't hear you. Always home, don't usually have stream to the TV because I fall asleep. My fiance will tell you about it later.
Stop reading out people's questions. Can you hear me better there? Okay, hopefully people can hear me better.
You might have to speak up.
Alright, I'll start talking louder. I'm good at talking loud. Just hope my toddler doesn't wake up because of it. Okay, so is that working? Can
Yeah,
someone give me a
supposedly.
thumbs up? That's better. Yeah.
That's better.
So
Good.
maybe if I do. Excuse me, we're just having some technical difficulties. Need that amazing Centrelink music. Hopefully that's better. Okay. All right, there's thumbs up. That's good. Okay. So, now I'm off track. The inductions that don't need to occur. So there's this really common questions in society, when are you getting induced? It's almost a given that that's going to happen to you these days. If you are healthy and your baby is healthy, you are not overdue at 40 weeks. A due period is 37 to 42 completed weeks. Now, if you need information on this because you are nearing that 41 weeks and induction is, hanging over your head, then head to Evidence-Based Birth. That's the most amazing website, and there's a really great article around due dates with really important risk. There is risk in everything that we do, and it's really important in everyday life, not just labour and birth, obviously. There's risk of doing something and risk of not doing something. When you're presented with risk, we're often presented with a lot of, in a fear-based kind of way. Now, if you're told that there is a risk of something happening 0.5%, imagine if we turn that on its head and say, well, there's a 99.5% chance that this isn't going to happen. So we often come at our conversations, come at medical conversations going, oh, this could happen and this is the risk, or there's a risk that this could happen. You're not often told the numbers. Often the numbers are really, really, really low. Now, yes, if those numbers are low, there are still people that it occurs to. Just like there are people that bad things happen to in our everyday life that we can't account for. So if you're told there is a risk of something happening at 0.5%, there is a 99.5% chance that it isn't going to happen. That's the most important thing. And in the Evidence-Based Birth, she talks a lot about absolute risk, which means that, that she defines it really well. I'm not going to go into it here, but head to that website and have a look at it if it's something you want more information on. So what I want to get at in this little section is that not all inductions are necessary. They don't all have to happen, and you have choices around them. So if you're just being induced because you're 41 weeks and 3 days, you're technically not overdue. Yes, your risk of stillbirth increases in that 41 to 42 weeks, but the risk is absolute. It's a point of 1, so I think it's 0.82%. It goes from 0.4 to 0.8%. So you may be told your risk of stillbirth doubles, but then when you actually look at the absolute risk, it's 0.4 to 0.8%. That's the double. So the risk is still actually small. So it's often the language that's used in how you're told things that then can instill fear and make you choose something that if you had a little bit more information on, you may not have chosen that. The other thing that's really important to know is there's always choice. So you can choose to have more monitoring, for example, a CTG and an ultrasound. Now, they're not predictive tests. They can't tell you what your baby's going to be like tomorrow. They only tell you what's happening then and there. So it's something that you have to be comfortable with. The risk is something you have to be comfortable with. Just like the risk of induction is something you have to be comfortable with, because there are greater risks with induction. The product information of syntocin says this can cause fetal death. It's it's a medically managed birth. There are much more risks involved, and I'm not just talking about the cascade of intervention, but that is probably the biggest risk in terms of having an epidural, having a vacuum, having a forceps, having a episiotomy, and then maybe having to have a cesarean. So please, if it's about that brain way of looking at things, remember we talked about that last week, so what are the benefits, what are the risks, what are the alternatives, can you wait an extra couple of days? And you're allowed to do anything you want. The hospital is not a prison. It's just about being confident with the information, making the choice that's right for you and your family, and discussing that with your care provider. What is your intuition saying? So many women say to me, oh, I've been told I need to be induced, but I don't feel like it's necessary. My baby and I are well, and I just want to wait a couple more days. sometimes you're over it. I've never been 41 weeks and 3 days pregnant. I've birthed at 37 weeks, and so sometimes you're just over it, but it will end. Pregnancy will end, and postnatal is forever, and 2 days in the whole scheme of things, when it could be the difference between a spontaneous vaginal birth that's incredibly empowering and natural with no intervention, compared to an induction that may last a couple of days and end up with a whole lot of cascade of intervention. The other thing with inductions are the longer your cervix, the tighter it is, the more closed it is, the more work the induction has to do. So if you go into an induction with an open cervix, that cervix doesn't have to thin out. And so there are options there as well. You might not have the gel. You might ask just to have your waters broken and wait 4 hours. So that's an option too. Sometimes you can say, I just have my waters broken, not get the drip straight away, and see if my body goes into labour naturally. And for some women, especially when they're in that 41-week zone, that's all they need. So we're going to talk about induction a lot more, but I know there's a lot of people coming up to it. So just, our induction rates are just skyrocketing. I know so many of us midwives are like, oh, another person being induced, for what reason? And sometimes there's a really fine line between is a baby healthier inside or outside, especially when there's sicknesses involved, like preeclampsia, and that's a serious issue, and we deal with it beautifully in Australia, and we save so many women's lives because we have induction and interventions. But if you're healthy and you're just being induced because of your gestation, you may want to ask you may want to talk about your choices a bit more. Alright, I'm going to ramble tonight. I can feel it already. It's just my brain's not working. The antibiotics, I'm going to make me feel really too, so we'll go from there. The other thing I wanted to do was recap on water birth. So I kind of skimmed over it last week. We're at the end of the session. We'd gone over time. And water birth is labour. So there's two things here. There's labour in water and there's birth in water. Two separate things. And it has been such a normal part of my practice that I often forget that some hospitals don't offer it, some doctors don't support it, and it's not an option for all women. So I wanted to kind of step back and look at that a little bit more, because I had a lot of questions after the last class. So there's actually a lot of history around water birth. There's stories or legends of Egyptian pharaohs doing it. I know when I was in the Solomon Islands, there were midwives in a certain area that had stories of women going down to the ocean to birth, and where we lived in our village in the Solomon Islands, the water was used, there was a current. It was current out the front, and that was used as the toilet, because there weren't any toilets in the village. Except for ours. Us privileged white people had our own toilet. But it's the ocean was very much a part of daily living, and so it made sense that it was a part of birth too, because it was a clean area, it was private in the village. And so there are still some places in South America and other remote communities where they use the river and oceans as for birth as well. So it's not a new thing. The first water birth recorded in the Western world was in 1803, and it was in France. And basically this woman had been labouring for days and days and days, and they decided to give her a bath to see, not for anything else, but just to try and relax her and keep her warm and whatever they did. And when she got into the bath, her labour sped up and she quickly birthed. And they were like, oh, maybe there's something to this. And so in the 60s and 70s, people started doing research around water birth, and there's some really cool stuff on this if you're interested in it. But then in the 70s, we had Michel Dont, who is a French obstetrician that all midwives love and not many obstetricians like. And he's all about the hormones. I'm not even going to bother with my French accent tonight, I'm way too tired. But all the stuff that I've been talking to you about, he has done extensive research on. And so what he found, that when women laboured in water, their length of labour decreased, their increase of satisfaction with labour increased, and that was because they had less pain, or they felt like they had less pain. And any woman that's ever been in a bath, and I missed out, I didn't get to get in the bath for my labour, but every woman I've ever known has absolutely loved it, and been like, I can't believe women miss out on that, because it's just this complete feeling of weightlessness, and the pain goes away. Now, we use heat packs for pain, and I know, women who have used them during their periods, or if they've got backache, and that instant relief of that in the area that you're applying it to. Well, a warm bath or deep water immersion in labour is exactly like that. It's like a whole body heat pack where your weight has been taken off, and you feel so heavy in pregnancy. To have that weight taken off is just phenomenal. And so that's where that decrease in pain comes in. Now, when you decrease pain and you increase that safety and security, you therefore increase the oxytocin, decrease the adrenaline, and that's where you get that decreased length of labour. So there's been a lot of research in this area now, and the biggest thing is that it decreases epidurals. So in New South Wales, about 10 years ago now, they did a Towards Normal Birth campaign. It was 2015, so not that long ago, 5 years. And so they had this campaign to really try and increase normal birth, and they had 10 steps, and one of the 10 steps was that every single hospital in New South Wales had to offer water birth. And that was huge. There was a lot of renovations and things that had to go around that, and I believe that there's still hospitals that in New South Wales that don't offer it. But that shows, that was the state government doing that, that shows the extent of research that supports water birth. Now, something like CTG machines, that's that monitoring of babies, they came in without any evidence at all. I've said that before. Where they've been shown to increase intervention rates, especially for healthy women, and yet most private hospitals will place a CTG machine on a healthy birthing person who is labouring on her own, and then they'll watch the machine out at the desk. And again, that's that factory birth. That's not how we were designed to labour and birth. They were brought in without any evidence. We're never ever going to get rid of them. Yet water birth has all this evidence, this supportive evidence. It says how it facilitates normal birth, yet women can't have access, or birthing people can't have access to them. And some people are saying they can access them water in labour in water, but not birth in water. So when I was with the Australian College, Australian College of Midwives, we worked a lot around trying to encourage places to enable all people of all risk to have access to labour in water. Not necessarily birth in water, but labour in water. And that's because of the benefits. And you can still have the CTG machine on, you can still have the fetal scalp clip, that's that clip on the baby's head. When you're in the water, there is nothing that prevents that. And if your care provider wants you to birth, they want your pregnancy to end, then the water is the best place for you to be for that to happen more efficiently. We know that. There is so much evidence around that. It just infuriates me that women aren't given this choice, because it's so well researched and because women love it so much. So it's something you really need to talk to your care providers about, and it should be a decision in choosing your place of birth as well. Water birth, that's going to be a different thing that is on your care provider. And a lot of these things that I'm going to talk about tonight around birth and placentas and stuff often come down to your care provider's comfort level. If your care provider is not comfortable with water birth because they haven't seen many, they haven't done them, they don't understand them, they haven't looked at the research, then they're not going to be a great person to support water birth, because they're going to bring that nervousness and that tension into the room. And if you know that your care provider hasn't done many water births, that's not going to instill confidence in you either. There's a lot out there about, we don't offer water birth, and then the midwives say, just don't get out of the bath. That's not, I did that 10 years ago when I worked in places that didn't support it too, and midwives would pull the plug. That's really, really dangerous care, because if a woman is comfortable in the bath and labouring really beautifully, and then you pull the plug, what is that going to do? Increase that adrenaline. What's that going to do? Knock off the labour. What's that going to do? Slow things down. What's that going to do? Not let baby come. Or if baby has come and you've quickly rushed and got her out, all right, your baby's out, but what about your placenta? And that can hold up that placenta in that third stage of labour, which we're going to talk about. So you have this comfortable woman in this amazing environment, you've yelled at her, you've pulled out the plug, you've told her to get out, and then all of a sudden we've just disrupted birth, and we've disrupted it at one of the most crucial points, because birth is not over until that placenta's out. You know, people really care about the babies, midwives and doctors, we really care about these juicy things, placentas. This was something that a woman brought me. So I mentioned last week that we had the only transfer I've ever done from home was from a bleed, and she actually had a retained placenta. And I mentioned how beautifully we handled that obstetric emergency, because we were able to keep the environment safe. We were able to keep those hormones that facilitated normal going whilst we medically managed the situation. And so she brought me a placenta, and she also brought me a little uterus keyring for saving her uterus. And my son loves this now, he plays with it. I don't have contact with her anymore, but one day hopefully she sees this and knows how much I love the placenta. So we're going to talk about that next, but just talk to your care providers about water birth, look into your options, do some research yourself. It is often, it's safe to give birth in water, and even if you're high risk, if you are more comfortable in water and that's going to facilitate birth more effectively, then why are we getting you out? Alright, I'm going to get off my high horse for that now. Pushing was something else. Someone asked me, about gravity. So we know that gravity can really help with pushing, and so gravity is obviously better on land, and so sometimes women, if they've been pushing a long time and that baby isn't descending in the pool, and this happens for women or people having their first birth, sometimes they'll say, okay, get out, try and push a little bit on the land, see if baby comes down, and you might be really comfortable, you might have dried off, you might be really warm and comfortable pushing in the position you're in, and you might just stay there. Other times, once we see that head, we'll say, right, get back in the bath, and birth baby in the bath that way. So it all depends on how that pushing stage, that second stage of labour is going, and how you're feeling with it. And what needs to happen. So as midwives, if nothing's happening, you've been pushing for a while, because first births can take up to 2 hours to push baby out. Some take longer, some take a lot shorter, but 2 hours is that general time that's given. And so if you're approaching that hour and there's not a lot that we're seeing that's showing us that baby's moving down, we'll say get out and use gravity. I really want to touch on that now, moving into the pushing stage. We don't want you pushing for hours and hours. It's not good for baby. So when baby, when you're really strongly pushing, obviously the cord gets compressed and baby gets squeezed, and so then when you relax, everything opens and allows for that blood to circulate back in better. If you're pushing for a long time, it tires you out and it tires baby out, and it increases the need for intervention. And so this is why I'm not a huge fan of doing a vaginal examination and saying, right, you're 10 centimetres, let's go. I'd rather see the other signs that I know that you're fully dilated, which show that your uterus has actually pushed baby down on its own without you physically bearing down and pushing. I hope that makes sense, but your uterus is constant, it's like a plunger. And so it's constantly moving baby down and down and down. And so we really don't want you to take over and push until baby's quite low. For me, I only pushed for about 10 minutes with my first birth, and that's because I'd let that pressure build and build and build. Albeit I was waiting for my midwife as well, so I was trying not to push. But letting baby move down and down and down so that I didn't have to do all that hard work. And that's why that urge to push is really important. So as baby's moving down, there are signs that we see as midwives that show us that you're fully dilated. And one of those is good old anus. It's giving you a little, starts winking at you. And I know, so I birthed on all fours, and your anus does turn inside out when you're pushing. And my husband afterwards was like, I didn't know what was happening. I didn't know what hole the baby was coming out of, because like this hole was doing something and that hole was doing something and you were upside down. It was all very confusing. Hopefully, no, he hasn't said. He said, way to get personal, babe. But it's true. Everyone's anus opens and extends as that baby moves down. And I also want to say it's not the business end, okay? It's a vagina. And if you don't want to be present watching the birth of your baby come out of a vagina, then that's okay. But please don't call it the business end. You get kicked out of my class for that. All right, so with pushing, you start to see that anus starting to wink at us, then you start to see that stretching of the perineum. And, you know, if you can't control it and you have to push, that's great. That's where we want you at. We want that baby so far down that you have to take over and push. But this whole, your 10 centimeters start pushing now, that's when that long pushing stage happens. We also see really long pushing stages when we do that directed pushing. And I touched on that last week. That's that, right, love, chin down to your chest, hold your breath and go for it. And look, I've had to do that in some births and some births call for it. But we know that that actually increases the amount of time you push. So it doesn't decrease it, it increases it. It also increases the need for resuscitation because you're having that really strong pushing, that holding your breath, and baby's getting more impacted from it. And it also increases the need for episiotomy. So that's what the research has shown, and that's Australian research by a colleague of mine who's absolutely brilliant and really fascinated with pushing. And so that's why spontaneous pushing, going with your body, doing it as you feel you need to, which is learning about your body, and why if you're doing my program, the Ulcha technique is really cool with pooing to understand how that body can actually work without your, a lot of exertion. So the other things I wanted to talk about with pushing was when you push in a squat position. So squatting has been shown to increase tearing, birthing in a squatting position. And I wonder if it's to do with the fact that sometimes women are up on their toes. So we talked about when you squat, your heels should be on the ground, but in our society we're really toey, and we lift our heels up, and that doesn't allow the pelvic floor to open and move away. And so I actually wonder, there's no research on this, but if that's why. The other thing that we know is when you're squatting down a lot of the blood pools in that area. And so if you are pushing in a squatting position, it's really important that you stand up between contractions, let that blood flow a little bit more, then come back down. And if you're in those later stages of pregnancy, you'll know that your vagina swells and you get fluid retention in that area, and it's just because it's really hard for it to come back up and circulate. So that's something that I forgot to mention with that last week. So with pushing, remember baby's position is really, really important for this. And that's why we want baby in that anterior position, because it's got to come under this bone and around this bone, and it always takes like 2 steps forward, 1 step back, 2 steps forward, 1 step back, and it does this little slidey thing to get round. In talking about babies' positions, babies are very, very clever, and they know how to navigate through the pelvis. Their bones aren't fixed, and so their bones can actually slide over. We call that molding. So their mold, slide over each other to decrease the diameters of the head. I'm impressing myself with some of the words I'm coming out with in my very exhausted state. So they slide over each other and decrease the diameters of the head to help it come under this pubic bone and around this coccyx. And babies sometimes come out with that cone head, and that's because they may have been coming down this way for a bit, and then all of a sudden they've been able to move through. So don't underestimate how clever your baby is. Of course it is, it's advanced, and knows exactly what to do. So we call it caput subcondium, and it's basically the cone head. When babies come out and they have that, it can look quite sore, and you can be a bit shocked by it. Just know that it's completely normal, and the next day, often by the next day, it's completely gone and it settles, and that's because our babies are champions, and that was meant to happen with their head. So that happens too. So when baby's coming under this bone and we can't yet see the head, it's a really great idea to be on all fours with the knees open, or any position where the knees are open. If you've got an epidural, or you feel the need to be on a bed or on the ground, laying on your side is much more ideal, especially for pushing, than on your back. And you can pop that peanut ball or some pillows between your calves to really open that space up and push down with that. And you might do that pull push with a sheet while you've got your knees quite open. So knees open in any position, but all fours is great, laying on your side. Once we see the head though, and this is a trick that not many midwives and doctors know, is that we actually need to close our knees. So Mr. Core and Floor,
Yes.
he's going to come and demonstrate. If you watch my stories today, you'll understand the reference to Mr. Core and Floor. But basically Mick got recognised the other day, and he got in the car and he's like, I'm Mr. Core and Floor now. So he's no longer midwife. Mick, can you come in, please, sir?
Yeah.
He's just watching this class to stay up to date.
I wrote this class.
You wrote this class, you did not write this class. You want to step the camera back a little bit, because you're just going to demonstrate this position because my legs are a little bit sore and I can't do it. Oh, we just lost me.
All good.
So we really want to slowly breathe baby out as much as we can, and that diaphragmatic breath in between the contractions to open up that pelvic floor. All right, can you see you on the ground?
Yeah.
Can you see my knees?
Yes.
Head, shoulders.
All right, I can see your knees. Go.
Knees and toes.
You're right.
Right, you're coming in here.
All right. All right, as long as I don't need to stand up as well.
No, just kneel. He
All right,
doesn't
haven't been pre-warned
actually
about this.
know what he's in for. So
All
turn
right,
around,
let's
face the other way.
How does it feel to have the roles reversed? Yeah, this is how we got pregnant in the first place.
Not this way. On all fours.
Yeah.
Do you feel a bit
I'm
vulnerable?
kind of scared right now.
Yeah, good.
All right.
Now place your knees together and your feet out.
Yeah.
Yeah. And then, oh, I could do so many things right now. Curl your toes in.
I could walk.
Curl your toes in. So this is the position you want to be in. Such a tack showing undies. When you're pushing your baby out where we can see the head. So before we see the head, knees open, wider. Come on, get a baby out.
Right.
So wide open. Yeah, stick that butt out a little bit.
Yeah.
Yeah. Now knees together.
Yeah.
We see the head, so I can see the head. His anus is winking at me. It's starting to pout. It starts doing that, and then we can see the vulva starting to open, and that's where you want to bring the knees in, curl the toes forward, and open. So what that does is it opens up these sit bones. These bones here, and it creates a wider space down below. So when our knees are far apart, it creates a bigger space here. When our knees are closed, it creates a bigger space and moves this coccyx away and opens these sit bones up. Thanks, Mr. Core and Floor. You wanted to be Mr. Core and Floor, that's what you needed to do. Alright.
Do you want to go back in it?
Hopefully you all enjoyed that. People have been messaging me wanting Mick to be more involved. And that was all I could think of for tonight. Sorry. Alright, so yeah, pushing is not like it is in the movies. It's not legs up in steerers going like that. Sometimes it is, and for some people it needs to be. But it can just be a way of actually breathing your baby out and going with that natural urge of the body. Alright. We did all that. The other thing I wanted to touch on, two things with tearing. Diet affects tearing. Diet affects everything. We know that. And look, I'm not well at the moment. I shouldn't be having sugar, and I'm still downed half a pack of Tim Tams this afternoon. But I do want to say pregnancy is not a time to sit on the couch and eat half a tub to a full tub of ice cream every night. It's especially in that second and third trimester when you are feeling a bit better. Really important to have a lot of plant-based foods because diet can affect tearing, and it definitely affects the way you labour and birth, and obviously it affects your baby's microbiome. The other thing is, if you are a horse rider or a bike rider, you like to ride bikes, get onto the perineal massage. You guys tend to have quite a hard perineum.
Cyclist.
Cyclist. Cyclist. Perineum's a cyclist now. I was at a place in Prague. It was an International Confederation of Midwives, so a big conference for midwives where we all get together and do this with each other. I'm kidding. Now I'm getting delirious. But we had this amazing presentation from Amsterdam because there's lots of cyclists there, and they were talking about how they have some of the highest tearing rates in the world. And so if you're a cyclist or a bike rider, there is a difference or a horse rider, perineal massage, I highly, highly recommend it for you. Alright, so your beautiful baby has been born. Now, we're going to talk about skin to skin contact, but I just want to say you have grown your baby for however many weeks you are when you birth, and you have thought about what it's going to look like, if it's going to have dad's freaky toes or your cute little nose, or dad's personality, calm personality. I always wanted my son to have my husband's personality, but he unfortunately got mine. You know, you think about all those things, and so when a baby's just smashed onto your chest like that, it's really hard to look at it. And when you birth a baby, there is this moment where you come out of your labour and you come into motherhood and or parenthood, I should say. Sorry, my language is not very inclusive tonight. But you go, oh, that's over, and now here I am. And you instantly become a parent. And you need that second between labour or birth and meeting your baby, but you also need to meet your baby. And I always try my hardest to ensure that a baby's first eyes it ever sees are the person who birthed it. And also I try and place a baby somewhere where the person can pick it up, and that's because you want to look over it. And if you've seen my birthing video, you'll see that I looked over my son. I didn't even realise he was a boy until he was about 10 minutes old, but I totally looked over and went, right, 2 eyes, nose, mouth, 2 arms. Okay, I made a good one. It's all right, because that guilt that you carry as a pregnant person is horrendous around if your baby's going to be okay, and if any little chocolate chip cookie you had is going to impact its HSC or VCE scores for the rest of its life. And some of you are probably laughing and others are probably crying right now because it's hopefully you've hit the nail on the head. But talk about that with your care provider, about having the option to actually meet your baby, be the person that picks it up and places it on their chest. There's no rush. You know, once we discovered skin to skin contact, we had this quick rush to really smash that baby there. Yeah, we want to dry baby down and make sure baby doesn't get too cold, but it can take a moment. And what else is really important when baby's born is that halo around the family, and you're letting that family get to know each other whilst we quietly go about the rest of the stuff that has to be done. I almost said business then. And I had to be really careful because I told you all off for saying that. Don't say as I do, do as I say. Okay, so third stage. So you've given birth to your baby, and then the most important thing has to happen, and that's you have to give birth to your placenta. And not everyone knows this, and not everyone knows that there's a choice. So babies come out, and what happens is the cord is still attached to baby. It's on your chest. Or it's on another parent's chest, and the cord hangs out of your vagina, and then inside is still the sac and the placenta. So there are 2 ways you can birth your placenta, and most people only know about one. The first one is the one I'm going to talk about. It's the most common, it's the one people know about, but you do have a choice, and this is something you need to talk to your care providers about too if you want to. So what happens is baby comes out, we now do what is commonly called delayed cord clamping. It's not delayed at all. Funnily enough, we were made to actually do all this on our own before we had machines that go bing and plastic cord clamps. So this is a typical clamp. That's what it looks like, and so it clamps down over the cord and it clamps shut. The cord itself actually has its own ability to clamp without needing anything, and so it's covered in Wharton's jelly. So you have your 2 arteries in a vein, and there's Wharton's jelly all around it, and so it actually clamps down and stops the blood flow from the placenta to the baby. Now, we've recently, in my time of practicing, come across delayed cord clamping, and so what we used to do is as soon as that baby was out, sometimes it wasn't even out yet, we would clamp and cut the cord. We now know that by doing that, we left about 1/3 of the baby's blood supply, so that's a blood transfusion, left in the placenta. And we now know that that blood is crucial for the baby for the first 6 months of its life, until it starts to eat, which is when it starts to get iron. And so now we've stopped doing that pretty much I would say nationwide now. It's become a practice, and it happens in caesareans, and it even happens in preterm caesareans. When it's an emergency, we still give that baby a chance to get its blood because it's blood transfusion. And so it's not delayed at all, it's just letting it be optimized, and so that's why a lot of us are pushing for that optimal cord clamping, to really get people to understand what naturally occurs anyway without us intervening. So the cord can be clamped and cut at any time, but if you choose to give birth to your placenta through something called active management, we clamp and cut the cord once it stops pulsating. We then give you an injection, typically into your thigh. Some places will give it into your arm. It's into the muscle, and it's of syntocinon, so that fake version of oxytocin, the same thing that we use for induction, it's just at a different concentration. So babies clamped and cut, it often stays on the birthing person's chest. It might go to the partner. I just want to say quickly with skin-to-skin contact and partners, we now know that if partners have skin-to-skin contact with their babies, within the first 24 hours, it rewires their brain and actually positively impacts the way they parent. Absolutely phenomenal research around this. And so they look at the brainwaves and the brainwaves of the partner, the other parent. You don't have to take your shirt off and be naked. You can just place baby under your shirt in there to have it. But please remember that. If it's something you are comfortable with, please try and do it in your baby's first 24 hours of life. So if the birthing person doesn't feel comfortable having the baby on the chest, then the partner can do that. Or another birth support person, grandma or auntie or sister, whoever you've got there. Okay, so we've clamped and cut the cord, we've given you an injection, and then what we do is we wait for signs of separation. So we wait to see that the placenta has separated away from the uterus, and the way we see that is we see this cord starting to lengthen, and we see a gush of blood. So just like in a period when the lining's coming away from the uterus, the placenta comes away from the uterus, and so there's blood behind it. And then what happens is the care provider will guard your uterus like this. So they'll place their hand on below your belly button, and then they pull the placenta out. Now there's no bones in the placenta, and it's a lot smaller than your baby, so it's not like birthing a baby again, but there is a bit of pressure, and typically that final sigh of birth relief happens once the placenta's out. So if I was doing this method of delivering a placenta, I would say, as I could see it, you're going to feel some pressure now, just breathe through, and we pull it down. So the placenta's got to follow the same curves of the pelvis. It's got to come under the pubic bone and then up around. And then what we often do is start to twist to get the membranes out, because sometimes parts of the placenta and the membranes can be left behind. So that's active management. As soon as that happens, as soon as the placenta's out, we stick our hand on your uterus and we rub it. And so it's gone, your uterus has gone from right under your ribs to your belly button. And we rub it to see what it feels like. And it should feel like a baseball. It should feel firm and directly in the middle. If it's off to the side, it often means that you need to wee, and we've talked about that. Importance of weeing during labour and birth to make sure there's more space in the pelvic region, but it also decreases bleeding post-birth. And so if it's off to the side, we'll try and get you to get up and go for a wee, and if you really can't, sometimes a catheter would be put in, because if that bladder's full, you do have an increased risk of bleeding. So your hand goes on the fundus, which is what we call the top of the uterus. I know it's a clever name, and we rub that. We don't, if it's firm and tight, we don't rub it for a long time. We just want to touch it and know that it is. If you are bleeding, there are 4 reasons that you can bleed, and the biggest, 70% of all bleeding comes because the uterus hasn't contracted down to stop the bleeding. And the first thing that we do is we rub that uterus up, because touch makes a muscle contract, and so we can stop a lot of bleeding. The majority of blood loss is stopped just by doing that. So that is a routine that happens after every baby's born. So baby's born, clamp and cut the cord. So you've got 2 options with clamp and cutting. All hospitals will have these, but you can also do this. So this is something I had for my son's birth, but it came the day after he was born, and it's actually a tie, and it's got a little gemstone on it. So if you don't like that plastic, basically it just gets tied up. Most care providers won't be, if you're not birthing at home, won't be used to using these. They may be a bit scared, but remember the cord is actually clamped itself, and you're just ensuring that it's all done. And if you've done that optimal cord clamping, all the blood has come out in that cord. You see it goes from this big juicy thing to this tight little white thing. And so you can use these, just Google clamp ties and you'll find them on the internet. I just wanted to let you know because there's so many options that people don't know about. So I know that's not for everyone, but it's nice to know that there's options. Okay, so that's active management. The other way you can birth your placenta is to do it on your own, and that's called physiological third stage. I'm going to say a few things about it before I explain it. One, birthing your placenta involves all the same hormones as birthing your baby. And so if you commit to a physiological third stage, and really birthing your placenta, regardless of how you're doing it, should have this same attention. It's not a time for Snapchat, it's not a time for calling people, it's not a time for turning the lights on and talking really loud and getting your phones out. You need to be as committed to getting that placenta out as you were to the baby. Your birth is not over until that placenta is out. And you know, I think a lot of things that we see in that third stage, which is birthing the placenta, and a lot of blood loss, has to do with not protecting that space properly and not protecting those hormones and letting that oxytocin decrease and that adrenaline increase too much. So that's the first thing I'm going to say. Second thing is your care providers won't be comfortable with this if they haven't done it. In my 3 years of training as a midwife, I never saw physiological third stage. It wasn't until I worked in caseload midwifery and I was trained in this technique by the midwives I worked with who were already skilled in it. And it's very, very sad and unfortunate that this doesn't happen more, because our bodies were designed to birth placentas just as they were designed to birth babies. So if your care provider is not skilled in it, they will try and talk you out of it around the fact that you may bleed more, and we'll talk about that in a second. But it's probably not a good idea to have this if your care providers don't know what they're doing, because they will mix methods and they won't care for you properly and do it properly, and therefore that increases your risk of things happening. So physiological third stage is where we don't clamp and cut the cord until the placenta's out. So we leave everything undisturbed. The baby stays attached to its cord. We don't give you the syntocin injection. We wait for the placenta to come out on its own, and once the birthing person feels contractions, we use gravity, which is, you know, sometimes getting up, sitting on the toilet, all the same things that we use to get the baby out. So why might you do this? Well, a lot of people think, I've just pushed my baby out, I want to push my placenta out, I want to do it all on my own, I want to do it as natural as possible, and we know that when you do it that way, you don't have any of the fake hormones and you have the highest doses of all those euphoric love hormones possible. So when you get the fake hormone, you get robbed of that surge of oxytocin after the placenta comes out. And there's no great research on this, but I've cared for many, many, many women who've chosen to birth their placentas on their own, and when they've been able to compare, say that they just feel so much better, especially around day 3, day 4 in terms of baby blues, not getting them, feeling so much more euphoric, and having a lot more balanced hormones in that postnatal period. And just that sense of achievement and confidence in your body. So A, you need to know that it's an option. B, the research in this area isn't great. So yes, postpartum hemorrhage, so bleeding post-birth, is a #1 killer in birth for women worldwide. We know that. In fact, in Australia, it's actually suicide. Maternal suicide is our highest cause of maternal mortality at the moment. So it's not the highest cause of death in Australia. But in low-income countries where they don't have access to technology and drugs, it's definitely a very, very serious event. And I'm so grateful we have hospitals and procedures to decrease bleeding. But the research in this area, I'm not going to go too much into it, but There's a lot of midwives that have, and there's a lot of information you can find out there when you Google. Just make sure you're reading really well-researched information and not just people's information and experiences, but actual studies. And again, look on evidence-based birth for this. But they did some studies back in the UK, and the controversy around it, so it showed that when we actively manage third stage, there's less bleeding. And so you will be told that if you choose physiological third stage, you have an increased risk of bleeding with it. Now, there were flaws to those studies, and that's that they mix methods. So when we do active management, there are specific steps that I just told you about: clamp and cut the cord, give the injection, guard the uterus, pull the placenta out. That's active management. When there's physiological management, we don't touch the cord, we let the woman birth it herself, we don't pull on the cord, we don't do anything, we just leave her. When you mix methods, you start clamping and cutting the cord for physiological third stage and pulling on it. And that's where we disrupt things, that's where we affect the oxytocin, and then there's bleeding. Physiological third stage is only for women at low risk. If you have a high risk of bleeding, or you've been induced, or during your labour and birth things have taken a long time, or you've had an episiotomy, or a vacuum, or a forceps, if there's any risk factors, then you really should have active management. And when I care for people, I tell them about their choices, and most women that I care for will choose to go for physiological third stage. In saying that, they're well aware that if any risk factors come up in their labour and birth that increase their risk of bleeding, that they'll switch to active management. Now, they know me, we've got this very trusting relationship, and so if during birth I say, hey, you know what, this happened and this happened, I think it's really important that you have the injection and we do active management, birthing people are fine with that because they understand the risk and they were well informed before going into it. It's not just a decision that was sprung on them. But if everything's been normal, they've birthed their baby on their own, there have been no interventions, I'll say, are you still happy to birth your placenta physiologically? Yes, and we go for that. So this won't be for everyone again, but it's important to know that you have a choice. For me, I had a home birth. I had fibroids, so muscle mass on my uterus. They were outside my uterus, so they shouldn't have affected the way inside fibroids, so muscle fibroids on the inside of your uterus can affect the way your uterus clamps down, because obviously there's a muscle mass there, so that increases bleeding. So mine were on the outside, so it shouldn't have affected me, but I was at home, it was my first baby, I really wanted a physiological third stage, but what I wanted more than that was to stay at home, and I didn't want to have to be transferred, and so I chose active management. Next time around, if I get to birth again, I probably, if everything is normal, I'll want that physiological, because I've proved to myself that I didn't bleed much and I did it all and I want that. And so it's really about choosing what's right for you, as everything that I've said throughout these episodes has been. Okay, so someone asked about, so the placenta is about 1/6 the size of baby. 1/6, so if your baby's 3 kilos, it'll be 500 grams. And I love to give Year 9 science tours of the placenta. There's lots of things you can do with it. I'm going to talk about, someone asked about marginal cord insertion. So this cord you can see is centrally inserted. So placentas are typically one piece with the cord inserted somewhere. Sometimes it's central, sometimes it's to the side. And sometimes you have an extra piece of placenta, what we call a suction turiate lobe, and so there's almost like you've got two placentas. Sometimes they're joined via vessels. There's lots of cool things that can happen with the placenta. And what's happened is our technology, as it does, gets better and better and better. And so I just don't know if you can see my undies or not, so I'm being a bit weird with my skirt, sorry. I know I've talked a lot about vaginas, but I don't really want you to see mine today. So what happens is ultrasounds are getting better and better and better, and we're picking up everything. We're picking up things that we didn't necessarily pick up before, and they may have meant something or they may not have. So a marginal cord insertion means that the cord is actually inserted closer to the edge of the placenta. And I actually cared for a woman recently with one of these. And so it can sound a bit scary, and people will be told that there might be difficulty in the placenta birthing. Now, it's really hard with things like this because it's great to have information, but information can also make people more fearful. And that's the least, we don't want you to feel that emotion because of adrenaline. Right, you're getting this, you're all on top of it. And so going into your birth thinking, oh, I might not be able to birth my placenta, I might bleed, it might get stuck, is not a great thing to be feeling, and it's not going to optimize it, and it might end up leading to that delay in the placenta being born because you're worried about it and therefore you've knocked off your oxytocin. So we just have to be careful, and if you have had, what we do when the cord is inserted on the side is that we're a lot more gentle and cautious because we don't want to pull it off. So sometimes what happens is the cord can come off and the placenta stays inside the uterus, and then what has to happen is what's called a manual removal. You often go down to theatre, you have the placenta scooped out, and often you put under a general anaesthetic. So you're removed from your baby and your partner or your birth support people, and it's not ideal, and it's not what we want. If you've got a marginal cord insertion and everything for your labour and birth has been normal, then the best thing for you to actually have is a physiological third stage, because no one's pulling on that cord. We're letting it come out on its own. And you know, sometimes pulling on that cord and really interfering actually interferes with the birth of the placenta because of those hormones. So exactly the same as the birth hormones. So I'm not going to go on about that too much. Hopefully I've answered whoever's question that was, but I've seen lots of placentas come out with marginal cord insertions. Early in my career we had no idea about them. We were just like, oh, would you look at that? And that still happens with placentas. Like, wow, cool, that was really awesome, this happened. We didn't even know about it. And we should be careful with placentas anyway. We shouldn't be pulling on them if they haven't separated. So if the placenta has separated and it's there, you're just gently pulling it out. It's called gentle cord, controlled cord traction is what we call it. Gentle is in the name of the technique. And so if we're not tugging on it, then we shouldn't be ripping any cords off. It's been strong enough to stay there for your whole pregnancy, be strong enough to come out with your baby. Okay, so oh, the other thing I wanted to touch on was something called a nuchal cord. So some babies, 1 in 4 actually, have what's called a nuchal cord, so a cord around the baby's neck. It is not an indicator for cesarean. It's actually really common, 25%. We don't have to clamp and cut the cord when the baby's head come out. So this is something that happened when I trained. We would clamp and cut the cord and then the baby would be born. Now you tell me, if we clamp and cut the cord, how is that baby now getting oxygen? So its head's out of the vagina, its body is still in the vagina, so it hasn't been completely birthed yet, bonded, and we clamp and cut the cord. Where's it getting its oxygen from? It's not. So when the head's out and the body's still in, it's still getting oxygen from its placenta. If we clamp and cut the cord, that baby no longer has any oxygen, and so it needs to come out really quickly and transition to extrauterine life, and it no longer gets its blood transfusion. And so optimal cord clamping and the research around that has really stopped this nuchal cord from being cut, but I still know that many doctors do it. It is not ideal, and if that baby then gets its shoulders stuck, it's got no oxygen supply at all. So it is a normal thing. Yes, it gets compressed, so we might see some decelerations on the CTG. If the CTG is hooked up, we might hear them through the Doppler, because it's getting a little bit more compressed as opposed to if it was just free flowing back behind here, but the baby's still getting oxygen, and once that head comes out and the cord is able to open up more, it gets a lot more oxygen through it. Cords are tricky things. They can actually have true knots in them. They're really fascinating and amazing, but I was at a home birth once, and we had to transfer in labour. So I know I said I only had one transfer, that was a birth transfer, but labour transfers sometimes happen. And we had listened to the baby's heart rate. It was really early in the labour, and we heard a deceleration, and so we had to transfer into the hospital. And everything else was normal, and pop the CTG on, and we constantly had these decelerations in this heart rate. And we know when we see those during a contraction, especially that it's a cord event. So what baby does is it squishes its cord, and I always think of Bart Simpson being strangled. Squishes its cord, lets it go again. So it's like, oh, not getting oxygen, lets it go. And it did it the whole labour, and we were like, oh, that cord is involved somewhere. I wonder where the cord is. The baby came out and it had the cord wrapped around its little foot. So every time it got a contraction, it was like bungee jumping on this cord and compressing it. Baby came out absolutely beautiful. Birth was amazing, and she'll probably have a home birth next time. But it was, yeah, that tricky little cord around the baby's foot. So sometimes we see that, and it's, you know, we know what it is, but we don't know where it is or what it's doing, but it's not a reason for caesarean section if everything else around the labour is normal. The other thing I wanted to tell you about was lotus birth. So again, not for everyone, but it's good to know it's an option. A lotus birth is where you would have a physiological third stage sometimes, but I have seen these done during caesarean section. And you keep the placenta and the baby attached until it naturally falls off. So when we place a clamp or a tie on the baby, typically the cord falls off when the baby's around 4 to 10 days old. And we'll talk about that. I'm going to do a whole section on baby carrying and nappies and all that later on in a couple of weeks' time. But 4 to 10 days, it normally comes off. A lotus birth is where you keep it attached, and the placenta gets its own little bag, and you put lavender and salt in it. And I always say, if you're not a fan of, you know, in-laws or some people that you don't want to come around, it's a good idea because it keeps them away because they're grossed out by it. Obviously COVID's doing that. It's probably not a good joke in this pandemic. Sorry, that wasn't appropriate. Should have thought that one through. But you can keep them attached until it naturally falls off. So that is an option too. Not many people choose it, but it's nice to know. So the whole idea is around attachment, and the baby chooses to get rid of its cord when it wants to. So what can you do with your placenta? These are my favourite things. I love them more than I love babies, except for my own baby. And that's because it gave your baby life. They're just phenomenal, absolutely phenomenal things. It kept your baby alive, it grew your baby for your entire pregnancy. So some people just spin it. Some people choose to look at it, see what it looks like, get photos. You can do really cool photos where you make like the cord, a little love heart. Hey, Mr. Coram Floor. Yeah. Can you come here for a sec, please? So you can choose to just bin it, and the hospital will dispose of it. If you have home birth, you have to eat ice cream. It's the only time you're allowed to. You eat an ice cream bucket, you pop it in there, and you pop it in your bin.
Can you just go pump you again?
No, I'm not pump you again. Hey, in the study, just between the desk and the wall, there's the placenta print. Can you get that? So some people do that. Some people encapsulate it. I'm not going to go on a lot about that. It became really popular. The Kardashians made it popular. Some people swear by it, say it made them feel absolutely phenomenal post-birth. They absolutely love it. Other people are totally grossed out by it. It's an option. Look into it if you want to. The research around it, thank you. There's some good research and there's some not so good research. I think a lot of it has to do with the fact that if the blood's already drained from the baby, from the placenta into the baby, there's not as much nutrients left. I also think you have to be really careful. Our microbiome, so all the bugs that live on us, aren't as good as they used to be, and we do carry things like GBS and stuff like that now, and so it really has to be well washed and prepared. The other thing to think about is if baby's done meconium inside. But yeah, some people love it, some people don't. You can do your own research into that. The other thing you can do, and people talk about, I've never ever met a person that's eaten it, like sat down and eaten it. Obviously when you encapsulate it, it gets dried, gets cooked in an oven and dried and put into capsules and you ingest it, but you don't eat it. Animals eat it because of prey. So it has a really distinct smell. Midwives know, only midwives know, doctors know a placenta smell. And when you've birthed a baby in the wild as an animal, you don't want other animals to come and eat your baby and know that you've birthed. And so eating it is a way of disposing of the evidence that you have young. So just wanted to touch on that. It's not something that humans have typically done. You can do what's called a placenta print. So this was our placenta print that I was clearly going to get framed, and it's been hanging out in the study for 3 years. And so that's the actual placenta and then the cord. And so to most people it just looks like a tree, but I know it's the placenta. And that's actually done with blood. So if you get it encapsulated, some people will do cord art, where you get the cord written in like the baby's name or the word love. And other people will do this as part of encapsulation. We just did this ourselves with some creative paper. And then we actually, I'm a midwife, I love placentas, we buried it. It's meant to be high in nitrogen, so it's meant to be good for some plants. My son was born in autumn, and so I buried it under a Japanese maple, and it's the only plant in the garden that isn't doing well, the only tree. But he knows it's his plant, and so we have to keep it alive. But it's not doing very well at all. I probably didn't choose the best. It wasn't probably the best plant choice, but anyway. So there are different things you can do with your placenta, and some people are fussed. They want to do something and others don't. If you've got older children and you do want to plant it, it can be a really beautiful thing to actually decorate a pot and then plant it in there, and it becomes really special. But my son knows that that's his tree, he knows his placenta's planted underneath it, and it's a kind of a really cool thing that reminds me of how the most empowering event of my entire life every time I go out into that garden. So don't let that plant die. Alright, so fundal massage we've talked about. Let's go on to stitches. Hopefully I covered everything with that third stage. I'm not too sure that I did, but hopefully I did. I'm gonna kick people out of my class if they talk about something called the husband stitch. So you're gonna get kicked right out. I am tired, so I get cranky. But the husband stitch is where you may have heard, and literally in 13 years, I think had 3 people ask for it. There's 2 things that you don't want to do post-birth. That's say that you've caught a fish bigger than your baby weighs. I've had that comment a couple of times. Don't say that. And the other thing is to ask for a husband stitch. So that's where you ask for extra stitches to be put into the perineum. If you're giggling now or smirking and your partner's just shot you a look, I'm sorry, because I've just got you in trouble and there may be an argument after this. I can't be held responsible. Like I said, I think I've had 2 or 3 people ask for it in thousands and thousands of births that I've been at. It's very minute, but it is a form of abuse, and it's not funny. And after a woman's just given birth, it shouldn't be a comment that anyone in the birthing room makes, because it does still happen. I haven't seen it ever happen, but I know it does happen, and it is higher in different cultures. It is. You are doing cosmetic things if you are putting extra stitches in. So when people get stitched up, we are putting things back together the way they were naturally formed. And so extra stitches are not safe. They are not recommended, and it's not funny. All right, did you just see the cranky side of me? Sorry, I just really wanted to touch on that because it is something that sometimes comes up. Okay, so people ask about how many stitches did I get. It's not about 1, 2, 3, 4, that kind of thing. It's often a continuous stitch. And so there's a difference between tearing and grazes. Grazes are like, remember, take yourself back to primary school where you used to fall over a lot. I fell over a lot. And you get grazes on your hands. That can happen on the inside of your labia, so your lips. And they sting. I was intact, but I had grazes, and my God, did those sting when you do a wee. And so it's the acidity in the urine that comes in contact with the graze that stings. And so trying to wash the wee away with water as you wee and decrease the acidity of your urine by drinking Urol really helps. The other thing that's really handy is to sit on the toilet backwards. It sounds weird, but it changes the direction, and so it enables it to go away quicker. So it's what happens, baby's born, placenta's born, we check your fundus, and then we check you for stitches. It's the cruelest thing we do because you are sore. You've just pushed a baby out there, and then we have to get some combine, and so like some gauze, and we part the labia from the top, and we check everything. So we check the clitoris, the urethra, and we come down and see if there's any grazes or tears. And this bit hurts. It's not nice, and you can use gas. So if you haven't used gas and stuff during your labour, you can actually ask to use gas for that bit. Baby's out. you shouldn't have to be uncomfortable for that bit, because that is a pathological pain. And so you get checked. If you need stitches, you get a needle that numbs the area, and then you get the stitches. So you feel the stitches in terms of tugging and touching, but it shouldn't hurt. If it hurts, then we go back and give you more numbing or anaesthetic in that area. And then often we can put analgesia into your bottom in the form of like Nurofen and Panadol goes into the bottom, and so it is local in that area, and then ice packs. So I'm going to talk about all that post-birth stuff in another session. But there are different tears. First degree tear means it's gone into the skin. Second degree means it's gone into that muscle. Third degree means it's gone into the anus partially, and fourth degree means it's gone the whole way through. So third and fourth are not very common, and using warm compress during birth decreases those, as does just breathing your baby out and being really spontaneous in your pushing. So if you need stitches, the stitches are done, and then you are left with your baby. And that's really when we want that halo to happen. And then you'll have the best shower of your entire life. Nothing beats that post-birth shower. It's so divine. So when your baby's born, there's a couple of things I really wanted to talk about, because people often get shocked about this when they see it. So babies are covered in white cream called vernix when they're in the uterus. And so that vernix starts to come away the more your pregnancy progresses. And so a baby born at 37 weeks will be covered in a lot more white vernix than a baby born at, say, 41 weeks. Same with little wrinkles on their feet. So a baby born at 37 weeks won't have as many crinkles and wrinkles as a baby at 41 weeks, and that's when we start to see their skin peeling. So that's really normal. If your baby is later in its gestation, their skin might peel, their skin might be wrinkly. They will be the most beautiful thing to you, don't worry. You'll only look back on photos later and go, oh, they weren't as cute as I thought they were. But that's the vernix. So if we could bottle it up and sell it, celebrities would snap it up at hundreds of thousands of dollars, because it is incredible. It keeps their skin, it's the reason their skin is so soft, and it protects them in utero. The other thing they're covered in, and I'm not going to say this right, and midwives out there are going to laugh at me, is lanugo. It's basically hair. So babies are also covered in all this hair, and so when babies are born, their parents might exclaim like, oh, why has my daughter got a really hairy back, or why has my daughter got really hairy shoulders, and you might get freaked out by it. It's completely normal, and it goes away. Obviously some cultures have more hair than others, but that is a thing that fetuses or a fetus has to protect them again, and it does go away. So babies are typically quite hairy. So that's something I wanted to touch over. The other thing is that we want to leave baby skin to skin with the birthing person for as long as possible, especially until that first breastfeed occurs, if you want to breastfeed. And so what skin to skin contact does is it's amazing. I think I always say if Kim Jong-un and Donald Trump had a little bit more skin to skin contact with their mothers, that they may not, the world might not be in the position that it's in. That's how much I love skin to skin contact. There's a book called The Scientification of Love. It's by Michel Odent, the French obstetrician. It's like this thick and you can read it in a day, but it talks about skin to skin contact, and it's like throughout history, and it's amazing. Like it looks at gladiators and how they were separated from their mothers from the moment they were born in order to be raised in a hard, mental, cruel kind of way. It's just a phenomenal book. Mr. Cornfloor really loved it as well. So it's The Scientification of Love, and it talks about how skin to skin contact is the start of being able to love, and how different cultures have embraced it and what that has led to, and how other cultures have not enabled it to happen for certain reasons. It's really, really like mind-blowing stuff. Okay, so skin to skin contact. It regulates your baby's heart rate. It regulates your baby's breathing. It regulates your baby's blood sugar, so really important for diabetics, especially. It increases or decreases your baby's temp. So what happens, and this only happens in the birthing person, is this area of the chest, if it recognises that your baby is cold, it will increase and heat up, just this area. If it recognises that your baby is too hot, it will decrease its temperature. It's absolutely phenomenal. Babies were meant to be placed here, and that's why it's so important. The other reason it's so important has to do with the microbiome. So when a baby's born, it's sterile. If you've had antibiotics in labour, then it's had those to its immune system first and foremost. When it comes out, it passes through the vagina. There should be around 500 different I almost said orgasms. Imagine having 500 different types of orgasms. Wow, that would be, I'm getting distracted. 500 different types of organisms in the vagina that it comes in contact with and starts to colonise with. And then it starts to colonise with what's on your skin. And so this is why skin-to-skin contact is so important, because it's giving your baby the good bacteria. It's starting to give it all the little animals, the fungi, the viruses, the bacteria, all the good stuff that needs to live inside it. And it also wires the brain, it increases oxytocin, which then stimulates the breastfeeding, decreases the bleeding. When your baby's born, it's born with this thing called a stepping reflex, and I like to show all parents this is my magic trick. But you basically hold the baby up and it starts to take its first steps. And it only has that for the first 3 days of life, and that's to be able to find the breast, but also massage the uterus. So the baby's feet are massaging the uterus to decrease bleeding. I know anyone would think that we were designed to do this together, us birthing people and our babies. So there's a lot to it. We're going to talk about breastfeeding. I'm going to do a whole section on breastfeeding, but I wanted to just touch on that quickly today. Midwives don't have scales in their hands. We don't know how much your babies weigh when they come out. Most of us are pretty good at guessing, but it's not something that we know, nor is it something we need to know straight away. It's something that we expect in society. So when you say there's been a baby born, everyone says, what's its weight? And for some reason in Australia, we still talk in pounds and ounces, not that we talk in pounds and ounces in any other moment of our life. But what I'm trying to get at here is that first breastfeed should happen before the weight's done. We don't want to interrupt that skin-to-skin contact or that first breastfeed. Even if you just want to give the first couple of breastfeeds and then formula feed, we don't want to interrupt that until with doing the weight and the length and the height. That can come later. And sometimes the baby will poo during that time. It might have pooed during birth and it might wee on you. And at that stage you don't really care. But the baby's typically naked. Sometimes people put a nappy on, but we just don't want to take the baby off the birthing person if we don't have to. If we do, it goes on another support person for all those lovely reasons that we just talked about. So yes, we wait for the weight. Alright, vacuum forceps. We're getting through this. What time are we at, Vicky?
20 past 9.
Oh, why do I always go? I thought I was doing well tonight. Alright, vacuum and forceps. So 1 in 4 first time birthing people will have a vacuum or forceps. That's really high, that's 25%. And then 1 of 3 of those have cesareans, so there's not a lot of room for vaginal birth left after that. I want to say, if you've had a vacuum or forceps before, and if you had an episiotomy, it does not mean that you're going to have it again. And this is why second births are my absolute favourite, because you birth with so much more confidence, and things just happen a whole lot smoother and easily the majority of the time. Doesn't always happen that way. But so many women that have a vacuum and forceps and a PIS for their first birth have a beautiful spontaneous vaginal birth with no intervention second time around. So just because you've had it before doesn't mean you need to have it. We know, we talked about last week, that having a baby at home, if you're a low risk woman, decreases vacuum and forceps for your second and subsequent birth. We're seeing that over and over again. So place of birth does affect this. I have seen beautiful births, beautiful vacuum births and beautiful forceps births. I just want to say that, and empowering births at that. But it's not always the nicest thing to watch. There is a lot of force involved, and as a birth support person, you may not want to watch that. So just be mindful of that, and the birthing person may want you up with them, holding their hand and wiping their brow, coaching them through. But if you had planned to catch the baby or watch the birth and then it turns into a vacuum or forceps, you may not want to be a part of. We won't be a part of the actual birth, but you may not want to watch it. Lots of women, or birthing people the whole way through their labour will say, I can't do it, just pull it out, and you doubt yourself the whole way through. That's a really common thing. And what often gets said is just pull it out. What you need to know is when a vacuum or forceps is applied, so this is a type of vacuum, you still have to push. So it's not that we just pull the baby out and it's smooth sailing and it's really easy and it comes out easy. It doesn't. There is a lot of force, and I have seen many a times that doctors put their leg up on the bed and pull. It doesn't happen so much anymore, but there has to be a lot of force to bring that baby through. So you're pushing and they're pulling. So don't think it's the easy option out. It's not. It's actually a really, it might make the birth happen quicker, but there is a lot to it. So vacuum gets done. So I tried to do this on a doll and Elmo to show you what it did, and it didn't work, and I'm not going to do it on myself because there's quite a lot of pressure. But this gets placed on baby's head, and then it pumps up and it creates suction, and then we pull. And sometimes it pops off and it goes back on again. Typically that should only happen 3 times, and then we should say that, all right, this hasn't worked and we're not going to continue with doing it. So it gets placed on, pumped up, and then wait for a contraction. The birthing person pushes, so only with the contraction, whilst the doctor pulls. So obstetricians do this. This is not what midwives are skilled to do in Australia. Some midwives are in other countries, but not in Australia. And I did them in the Solomons, but with guidance from midwives who've done it before, and that's because we didn't have doctors around. So we pull up, and we're doing the exact same thing, following that curve, so coming under the pubic bone and over with your effort. Forceps often get done when the baby's a bit higher, and I don't have a pair here. That's a vacuum I've had around for a long time, but I don't have forceps, and they just basically look like steel salad servers. What a lot of people don't realise is that forceps are actually used a lot in caesarean birth, both in emergency and in elective. If the baby's quite low in the pelvic region and it has to be lifted out, that's often what happens. So the forceps go on and baby gets pulled out. So if baby's high, forceps will be used. Forceps, they're starting to come back a lot. They're a thing that people stopped. A lot of obstetricians didn't train in for a while. We were doing a lot of vacuums, and so forceps weren't done, but we're starting to see more of them get done too now. Sometimes you'll be taken down to theatre, especially in small hospitals. You'll be taken down to theatre to attempt a vacuum or forceps birth, and if that doesn't happen, then they'll go into caesarean. So that is affected by the skill mix of people there, the hospital that you're in, and your situation. So if baby's stressed out, and the reason we're doing a vacuum or forceps is to expedite birth, get baby out because there's some fetal distress, then we want you in a place where if it doesn't work, we can quickly do a caesarean section. If baby's well and it's just a case, or not just a case, but you've been pushing for a long time, and so they want to hurry up and finish the birth and get that baby out, and baby's really quite low, you won't be taken downstairs. So it's very much, not downstairs is what we refer to it, okay. You won't be taken to theatre. It's very much a individual case-by-case thing. So reasons why vacuum and forceps happen, the most common reason is fetal distress. So we're worried about baby, we want baby to come out, and so we do that. They're common, more common with epidurals because you can't feel to push, especially if the epidural is dense, and so with all your might you push and push and push and push, and we don't see baby come down, and so we need to do that. Baby has to be low enough to be able to do this, so you can get it fully dilated and not be able to have vacuum or forceps if baby hasn't moved down, which is why with epidurals we give you that 1 hour to allow your uterus to actually push baby down low enough and then start pushing. Long second stage, so if you have reached that 2-hour mark for your first baby and an hour for your second, and baby hasn't come, there'll be people knocking on the door wanting that baby out, and again that the forceps or vacuum will be offered. If you and your baby are well and you want to keep going, the heartbeat's fine. You might have the monitor on by this stage because we're a bit worried that all that pushing's not going to be great for baby. But if things are going all right and baby's moving down and we're seeing progress, just because it's been 2 hours, again, you don't have to have intervention. It's your choice. It's often a case of what's baby doing, what are you doing, and you may be exhausted but you may want to keep going and it may be working. If you're exhausted and you want to keep going but we're not seeing any movement in baby's head, there is no point in just leaving you there. Obviously, we try lots of different positions. We get you to move around. Sometimes, if your midwives are skilled, they'll do spinning baby stuff to try and just get baby's position a bit better to come down. And so those things may work. Otherwise, they'll go to vacuum and forceps. There is a higher chance with vacuum and forceps that you have an episiotomy. Again, it's care provider linked. So some care providers can do it without, others will do it with. It's what they prefer, so it's a good thing to talk to your care provider about what they prefer to do and what they want, just so you know that if this happens, that this is going to happen too and it's not a shock. Baby's position is a big one for vacuum and forceps, and so sometimes what will happen is they'll, if your baby's posterior, they'll try and rotate baby and turn baby around internally and then pull it out. So that's why positions in pregnancy, seeing an osteopath or physio is really important for correct alignment, exercise and good diet and all those kind of things. And not spending a lot of time leaning back all the time on the couch, and if baby is posterior, getting it into a good position without freaking out about it, because babies can be born posterior too. And babies know how to be born, so having that faith that if that's the position your baby wants to be in, then that's the position it might be birthed in, and it'll be okay with that. So babies do have a sore head when they've had these instruments applied to their head, especially the vacuum. And what we often see with a vacuum is a Kefler hematoma, which is a pooling of blood under the skin and outside of the skull. And it looks really sore, and I can imagine that it would be. But again, it does go away. Sometimes there'll be scabs, sometimes there'll be scars, but often the hair goes over it. And with forceps marks, and you'll see it even if you had a cesarean, red marks on baby's face. Sometimes those marks turn into sores and scabs and scar. Often they're just red marks, and they go away within that 24 hours. Babies are really resilient and they bounce back from birth really beautifully. If you have had a vacuum or forceps, your baby has been pulled out, and so it hasn't been able to go through the mechanisms of labour that we talked about last week. And I highly recommend having a baby cared for by an osteopath that uses really gentle techniques, because it can be the difference between really great breastfeeding and not sometimes, because baby's got a sore head, doesn't want to feed on one side, and you'll see it in your baby, they'll move this way but they won't move that way, and their movements will be all one-sided, and it often means that they've pulled something or something's tight. And so getting them checked over, there's so many women. We have an amazing osteopath here. I just still don't know what she does, but she works magic. And women will go to her and, not be able to breastfeed, or breastfeeding's not been going well on one treatment and they're, baby's feeding. So, really important thing to remember that, and just to give your baby time to recover from its birth, just like you need time to recover, and ease into breastfeeding. And if there has been bruising, there is an increased risk of jaundice, and so that can then affect what happens in those early days. But keeping up on the expressing, and we'll talk about all that in the breastfeeding section. There is also a risk of bleeding and shoulder dystocia with vacuum and forceps. Shoulder dystocia is where the shoulder gets stuck on this pubic bone, and again it's because we've pulled baby out and not let it done its dance moves, and so we've pulled it out and its shoulders got stuck on there as it comes down. So just know that there is an increased, the more we do, the more we have to do often, that cascade of intervention. But what vacuum and forceps do that I absolutely love is that it can prevent the first cesarean, and preventing a cesarean is an amazing thing to lead you to be able to have really empowering, incredible future births. And that is a big key in our maternity care at the moment, is trying to prevent that first cesarean, so really decreasing it down to that 10% that WHO says. So having that first birth, sometimes, and it's really common that the first birth can happen like that, and then moving into that second birth with that confidence, knowing that your body can do it. Hopefully I've still got people on here as we go into VBAC. So I know lots of you have been waiting for this, and some of you are probably going to bed and will watch it in the morning. So VBAC, it stands for vaginal birth after cesarean, and if you're having your first baby, it's probably really important to continue to watch this section in case you do end up having cesarean, so that you know this now. So VBAC, vaginal birth after cesarean section. Everything that I've talked about in the first 3 episodes applies to you. Exactly the same. It's exactly the same around hormones and managing pain and techniques to use, all applies to you. But I'm going to go into a little bit of research and things that specifically apply to VBAC. So the 2 biggest things we see with vaginal birth after cesarean are 2 recommendations. The first one is to have an IV cannula, which is a plastic tube. I'll post a picture. I actually took a photo of mine today so that I could do this tonight, so I'll post a picture to the stories. So it's a plastic tube that goes into your vein. So we break the skin with a needle, we put the tube in, we take the needle out, and then we have access to your veins. So it is recommended that if you are attempting a VBAC, and I hate that word, you are going to have a VBAC, you have a cannula and you have continuous monitoring with a CTG. So last year, the NICE guidelines, they're UK-based guidelines. The UK is very progressive when it comes to this stuff. You know, they're so much more progressive on home birth and stuff like that than Australia is. And the reason we have amazing midwifery in Australia is because we've got UK midwives out here to train us and tell us what was happening over there, basically. But they have now said, as of 2019, that this, for healthy women, they no longer recommend having the cannula or the continuous monitoring if you're a well person having a VBAC. That hasn't crossed over to Australia yet. So in all places, you will still be recommended to have a cannula and a continuous monitoring your whole time. They are recommendations. Again, they're choices. So the reason they want the cannula is because in case you have to go for a cesarean section, we have access. So what they're worried about is rupture. So you have a scar on your uterus from a previous cesarean, and we're worried that that scar will rupture. So let's look at the risks first. I was always informed, and some research, most of the research still states that your risk of rupture is 0.5%, so 1 in 200, or 99.5% chance that it's not going to happen. RANZCOG, which is the Royal Australian and New Zealand College of Obstetrics and Gynecologists, so all the obstetricians, their peak professional body, their evidence on this, I was researching for this, actually said that it's 5 in 1,000 attempts, which brings your risk down to 0.005%. So 99.995% chance that it's not going to happen. And so obviously if the uterus ruptures, it's an extremely severe event for the mother and the baby. So the uterus ruptures, the baby, the placenta can come away and that baby goes into distress, and we need to get the baby out straight away. So if your uterus ruptured, it is a straight emergency cesarean, and that's why we love Caesars, because they're life-saving in that moment. Of the 0.005% of people whose uterus will rupture, 1 in 7 of those, so 14%, there will be a serious adverse outcome, so for the baby, so death or brain damage, brain injury. So 86% chance that it won't happen if you're in that 0.005%. So some of you are like, what? Can you write that down? Go through, rewatch it, write it down, look up the guidelines. But basically it's very, 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 very small. It is a risk. There will obviously be some people that happens to. I've seen it once in 13 years. It's not a nice thing, but we had great outcomes. And so for 86% of those 0.005%, they will still have really good outcomes for mum and for the birthing person and baby. So that's it. We've covered risk, yeah? So anywhere from 0.005 to 0.5%. So in Australia, we still recommend that you have the cannula and the continuous monitoring. So the cannula is just in case. The reason people don't want a cannula is because they don't want to go in to their VBAC thinking that they're going to fail, being set up for failure, just in case you need a cesarean. You're already being set up. Like my arm is still sore from like, I'm a big wuss when it comes to pathological pain. I can birth a baby without drugs, but try and take the sticky tape off my hand from a cannula and I'm like in tears. But having a cannula, it's an intervention, it's a disturbance to your labour, and the argument that people put forward when they don't want one is that if you were labouring spontaneously and on your own, there is always a chance that obstetric emergencies are going to happen, and there's always a chance that you may need a Caesar like that, or you may start bleeding. So you can have a beautiful normal birth, vaginal birth, sorry I shouldn't say normal, a vaginal birth, and everything is fine, and then you start bleeding and we need to put a cannula in. We are trained professionals at putting a cannula in. Yes, it is easier to put one in when you're at the start of labour, your veins are bigger and juicier, you're well hydrated. It is much easier to put one in then than it is once you've started to lose blood or in an emergency situation. Okay, so it's a preventative measure. So you need to know both sides of the story here. But just like when people have car accidents and things like that, we can still put them in. So it is a choice. It is offered to you whether you want it or not. And you may decide that you don't want one at the start of labour, and then if some complications arise that's making it look like your risk of having a cesarean or interventions may be increasing, you may then choose to have one. Continuous monitoring. So the reason for that is that when your if your uterus ruptures, it's really hard to talk and be good with language when you're tired. If your uterus ruptures, your baby's heart rate will drop, and that's one of the first things we'll see. I like to think that we will feel, people will talk about the pain. So when your uterus ruptures, there's pain the whole way. There's not just a contraction, relax, no pain, contraction, relax, no pain. There's pain there the whole time because your uterus is ruptured, and it's a very different pain, and your body responds by increasing its heart rate and all these different things to try and treat this injury, because that's what it is. It's a pathological pain and it's an injury. So the argument for continuous monitoring is that it will pick up the fetal distress and therefore pick up the rupture. Some people are confident that the risk of rupture is low, they are healthy, and they don't want that continuous monitoring because they know that it can lead to the cascade of intervention and other interventions. And so what they will choose to have is intermittent auscultation, which is the listening to the heartbeat with the Doppler. And they might choose, in a spontaneous healthy labour, we do it every 15 to 30 minutes. They might say, you know what, I don't want the continuous monitoring, but I want to have the listening to the heartbeat the whole way before, during and after contraction every 15 minutes. And so you're not tied to machines, you haven't got that, you haven't got the things on your belly, and you are just spontaneously labouring. So again, it's your choice. You may be more comfortable and that oxytocin may be flowing more with the monitoring, or you may be a person that's like, no, that's not what I want, and so you don't have it. The other thing is that people will often recommend you come into hospital earlier, and that's because they want to monitor you more closely. Again, it is your choice, and we know that earlier you go into labour, the higher your risk of cesarean, therefore the lower your chance of VBAC is. Again, if you're at home and everyone's labouring well and you're comfortable with the risk of 0.5%, let's go the top end of the risk just to be, a bit more cautious. If you're happy that 99.5% of people with VBACs won't rupture, and you're confident with that 0.5% risk, then you stay at home for as long as you want. So everything is your choice. It's just about discussing it with your care provider and being really well across the risks for both, because there is a risk. We know that the cesarean rate increases more and more the earlier you go into labour. So everything I've said in the last 3 classes applies to VBACs, if not more than it does for women spontaneously labouring. You can have vaginal births after 2 cesareans, and that is supported by research. I remember I was caring for a woman a couple of years ago now, and she'd had 2 cesareans, and I didn't actually think that she would have a vaginal birth. I supported her in her choice to do it, but I was quite negative, really, and I don't know why now. She wasn't a very healthy woman in everyday life, and the reasons for the cesareans, in the first place, she hadn't dilated, she'd had the cesareans quite early. Lots of things added up that weren't in her favour for having a vaginal birth. Well, she proved me wrong, and I love that more than anything else. I don't love being wrong in front of my husband, but I love being wrong around birthing people when I've made calls like that. And she absolutely rocked it, and I don't think I've ever met a person more proud of herself. The other VBACs, and VBACs and second births are my favourite. Another VBAC that I always remember was a woman when I was a student, and she had a cesarean, and she had all the complications that can come with cesarean, the not being able to breastfeed, wound breakdown afterwards, an infection, readmission to hospital, separation from a baby, all those kind of horrible events that take place around a first birth. And so she was really passionate about having a VBAC, and she rocked it. It was phenomenal. And I think it was probably the first VBAC I saw. She ended up with a 3rd-degree tear, and so into the anus, but not all the way through. And then one of the midwives turned around to her and said, I bet you wished you'd had a cesarean now. It was a really horrible comment to say by a midwife that probably should have retired. And she said, no, that was the most empowering event of my entire life, and I did it, and I get to take that with me for the rest of my life. And that's why I love VBAC so much. And she recovered really well from that 3rd-degree tear, and she didn't want to, never ever regretted her vaginal birth because she did it the way she wanted to. So you can have vaginal births after 2 cesareans. I've said that. The more vaginal births you've had after cesarean, so if you have a Caesar, then a vaginal birth, then you go for another vaginal birth after cesarean, your rate of success increases with every vaginal birth you have. Obviously, time between births is important. Some people recommend 18 months, some recommend 2 years between births, between pregnancies. It's around about 18 months, but World Health Organization actually says 33 months between births. That means you fall pregnant when on your first baby's second, or your most recent baby's second birthday. So that's obviously important because it gives the time for the uterus and the scar to heal. And if it's been less than 18 months, some places won't provide care for you because your risk increases. So that risk we talked about is dependent on many different factors. So it's not just 0.5% for everyone. And your chance of vaginal birth after cesarean is dependent on what your cesarean was for last time. So when you're thinking about risk too, don't forget that the risk of Caesar has a lot. There is a lot of risk with cesarean, from infection to cutting your bladder, to cutting baby, injuring baby, and lots of other things that we'll talk about in cesareans next week. They are a life-saving event, but they are dangerous in the Solomon Islands. We obviously didn't have the technology we have here, and they weren't as safe as they are here. And so once someone had 2 cesareans, they automatically, without consent, absolutely atrocious, but without consent, cut the person's tubes because it was just too dangerous. And I understood it, but it was a really hard thing for me to kind of accept because cesareans over there were just so dangerous. We don't have that here. We have very, very safe cesareans, and they're amazing life-saving ability, but they don't come without risk. So when you're looking at the risk of VBAC, you also need to look at the risk of repeat cesarean. And the number one reason we have cesarean sections, the number one reason people have cesareans in this country is repeat cesareans, which shows that people aren't being offered the choice of VBAC. They are not been educated and informed well enough about VBAC to choose from it, and they don't know all this stuff that we're going through. So often they have an emergency cesarean for their first, they were traumatised by it, they don't know this information that we've talked about around hormones, and they aren't able to, depact, I'm going to say depack, that's what I meant, their birth, and so they just elect to have a cesarean again. And if that's you and that's what you want, then that's awesome, as long as it's an informed choice and you know that there's options. So the success rate for vaginal birth after cesarean varies greatly in the literature. In Australia, there's anywhere from 29% to 82%, but typically the success rate is 70 to 75%, and that mimics what our cesarean rate is in this country. So going into any birth in Australia, you have a 70% chance of having a vaginal birth. If you are in a private hospital, you've got a 55% chance of having a vaginal birth, and that includes vacuum and forceps, because private obstetric cesarean rates are 45%, whereas in Australia it's around 30%. So if you're trying for a VBAC in a private hospital, your success rate will be lower than if you're in a public hospital, and you can choose to have a vaginal birth at home. It's called a HBAC, home birth after cesarean, and that is a matter of you discussing that with a private midwife if that's what you want. Not everyone will support that choice, and publicly funded home birth won't support that choice. Okay, so I'm just checking the notes here. So induction increases the risk of uterine rupture, and we really shouldn't be, some places won't induce for VBACs at all. They'll transfer to a higher place of care, or they'll just refuse. Other places like big city hospitals will care for women being induced. Ideally, you want to spontaneously go into labour to decrease your risk of rupture, but to also increase your risk of a vaginal birth. But if an induction is necessary, they don't like using prostaglandin, which is the gel. They'll use what's called a Foley's catheter. It's a balloon, and we'll talk about that next week. Some hospitals, they may just, if your cervix is already open, they'll offer to break your waters. Again, you can ask to wait 4 hours before having the syntocinon, but ideally we want you to go into spontaneous labour. But just know exactly what I talked about with induction at the start. There are always choices. Talk about that, try and work through it. So the reasons for your first cesarean do affect your success rate. So previous cesarean for baby in a, what we call a malpresentation, which isn't very nice, but things like breech, posterior, asynclitic head, transverse lie, that's an 84% success rate as compared with labour dystocia, so that's where the cervix hasn't opened. That's got a 64% success rate. But in saying that, I think if you are well informed and you know about labour dystocia and you're able to stay home and things like that, then you increase your chance. So it's very hard to put numbers on these things because it's so multifactorial. Fetal distress is another one at 73%. So that's just, I mean, it's some research, it's not the be all and end all. There are contraindications for VBAC. That's if you've had a previous rupture, obviously don't want to go there. And a classical scar, so that's where you've been cut down the middle of your uterus as opposed to that lower segment scar. Often people who have birthed overseas in low-income countries may have had that, or if you've had a baby at a really early gestation, say like 26, 28 weeks, and you've had a Caesar, you may have been cut that way. And there is obviously a bigger scar, it's along those muscle fibres, and it's not recommended that you have a VBAC. And then obviously any contraindications to vaginal birth, like placenta previa, which is where the placenta crosses the cervix. I made it. I'm done. My throat is dry. My leg is sore. I'm tired. But I've loved talking with you. I know we haven't had as big a numbers tonight. I think that's because some of you are birthing, and I'm loving hearing about your birth. So thank you. If you get in touch with me, I probably won't respond tonight, but I will over the coming days. Thanks so much for being here. Next week we're going to talk all about inductions, cesareans, twins, and breech. There's going to be probably a few more classes than I had originally anticipated because I like to talk and some of you would like to listen. So thanks for